Thank you very much. It's a pleasure for me to be here today. I will start the discussion on a meeting we had in Geneva, being myself the Italian representative in the executive committee of WHO. The meeting was held on February the 3rd in Geneva. And at that time, the world was unaware of the storm that was coming, because essentially what happened is that we had, of course, many cases in Wuhan, in the province of Hubei in China. And the Director General, Dr. Tedros, was just back from a travel to Beijing to speak with the President Xi Jinping about the emergency and the following declaration of the public health emergency that WHO declared at the end of January. I clearly remember that the recommendation that came out from that meeting was very clear. Unfortunately, they were not received timely by the world leaders. Essentially, what the WHO Executive Committee say that there was a threat, a serious threat from a new virus, which had a transmission via respiratory. And then, of course, that was an alert for everybody to take the appropriate measures based on evidence. And the world didn't listen. And at that time, even though being the representative of the Italian government in the executive council of WHO, I was somehow critical with my government, because at the beginning, the Italian government took some decisions that were not very strong in evidence-based. For instance, blocking the direct flight from China, in particular from Wuhan. At that time, there were 3 direct flights to Europe. One was to Rome, the second to Paris, and the third to London. And as you know, there has never been in the contemporary times a measure like that has stopped an epidemic. So only delayed it, because people, of course, do not have direct flights, but have indirect flights, and essentially the people still go on in coming. Having said that, on February the 23rd, I was called from the Minister of Health of Italy to advise and to take some advisorship responsibility to him and to the government for taking decisions. And I must say that from that time, we assembled a group of scientists, but also clinicians. And it was very important, was one of the first advice that I gave to the minister, to include not only epidemiologists and public health people, but also clinicians into the scientific committee. And actually, were essentially the president of the Italian Society for Anesthesiology, the president of the Italian Society of Pneumology, the president of the Italian Society of Pediatrics, and the president of the Italian Society of Geriatricians and Gerontologists. And this made a difference, because together, of course, with the expertise that we had in the panel before, which was essentially made by epidemiologists and public health people, we started to advise the Italian government to take important decisions. Actually, we were the first country to have a complete lockdown. The first lockdown was immediately acted in the so-called red zones in the south of Lombardy and in a village in Veneto. And then we rapidly extended the lockdown and other very tough measures to the whole country. What happened in Italy is that, fortunately, Italy was on the spot for some unlucky events, but also for some a little bit of delay in taking decisions. The first unlucky event was that the 0 case was essentially coming from Germany, and there was a manager coming from Germany to Codogno, which was the first city to have an outbreak in the south of Lombardy. And then, unfortunately, the patient number 1 was an incredible super spreader, both from the biological and the social point of view. He was very active. He is supposed to be in contact with more than 600 people. and having infected most of them. And unfortunately, he went twice to hospital. And in this hospital, he transmitted and he infected doctors, nurses, other patients, visitors in a very densely populated area and a very socially and productive, active area such as Lombardy. And Lombardy is also a place where the health system is very advanced, but the main pillar of the system is the hospitals. And essentially, we have maybe in Lombardy some of the best hospitals in Italy. And the nosocomial infections that came out from that first situation was terrible, because even in these very modern, efficient, and effective hospitals, the contagion spread all away, and in particular in the province of Bergamo, Brescia, Cremona, and in a province nearby in Emilia-Romagna, Piacenza, the impact was terrible. I suppose that also a major sport event really made Bergamo one of the most affected area, because actually on February the 19th, there was a major Champions League soccer match actually played in Milan, where one third of the Bergamo population attended. Was a major win for the local team, Atalanta, against the Spanish team, Valencia. And the people celebrated all the nights. And you can imagine how that has been instrumental to the virus to spread. And not by chance, also the few fans that came from Valencia going back to Spain were created one of the first on the first outbreak. Actually, when we realized with the Minister of Health of Italy that the situation was so bad, we made the first call to the neighboring ministers, essentially the ministers of health of the country surrounding Italy, plus Germany and Croatia, being Croatia the current president of the came immediately in 24 hours. We arranged a meeting with all of them in Rome. But at that time, the perception of the ministers of health of Europe, and first of the neighboring countries to Italy, was not particularly ready to understand that was not only a threat to Italy, was a threat to every single country. And actually, that was the case, because after a couple of weeks, the situation was pretty much the same in all the European countries. Actually, we can say that from that moment, the ministers of health tried to convince their colleagues, somehow unsuccessfully. We have to say that our support was very strong in convincing the whole cabinet, and in particular the Prime Minister of Italy, to take these tough measures. But it took at least 2 weeks for the other ministers of health to be able to convince their colleagues in the cabinet in different countries to take similar actions. And in these 2 weeks, the situation was pretty much the same. The epidemic curve is totally overlapping. So uncontrolled, these epidemics is terrible because it's a new virus. Everybody is susceptible, everybody is vulnerable, and you can have a rapid spread with a contagion including potentially many million people, and having, of course, thousands of casualties. And this has happened first in Italy, where in the very effective and modern hospitals of Lombardy, the pressures on hospitals was terrible, at the verge of sustainability. Actually, Italy was very strong in reacting. If you can imagine that in less than a month, the number of intensive care unit beds almost doubled, and the number of semi-intensive care also tripled. So Italy is a very strong reactive country when it comes to this event, and it has shown that this is the case also for these epidemics. But unfortunately, the number of casualties and the number of deaths is incredible. So we have paid an incredible toll of more, actually up to date, of 12,000 deaths. And these deaths has happened more many in the elderly people, but not only. A careful analysis of the causes of death by the Italian National Institute of Health has shown that all the people have died with the coronavirus. Only 12% of the people have died because of direct causation by the coronavirus. 88% had some forms of premorbidity, which somehow affected. That, of course, it doesn't, leave the situation unchanged from the tragic consequences, but at least make us understanding that there are some particularly age groups that have to be protected, and these are certainly the elderly, but certainly this is not only a disease of elderly people. Now, I would say that the world is aware. There has also been a very important collaboration at international level that we have once a week, and I think it has been instrumental, for instance, to the change of decision making in some countries such as United Kingdom and United States of America. Because I clearly remember when we had a meeting with chief scientific advisors to the most important countries in the world, including one at the G7, and I clearly spoke to the Minister of Health of UK, to the Secretary of State for Health of UK, and the Secretary of State of Health in the United States about the false assumptions that they had at that time, that this was a disease for elderly people, a little bit more than a normal flu, and that the herd immunity to be acquired in a similar way was an option. So I explained that was not the case. That was a tragic mistake that I don't think any government could allow to have millions of cases and thousands of deaths if the epidemic is not controlled. So what are the perspectives now? Now, in Italy, the lockdown is working as expected because the Wuhan example is clearly. It takes time, but after 2 weeks of a complete lockdown, the plateau, the number of cases is dropping. Is dropping not dramatically because the curve of the decrease is slow, but is evident and strong. So we are not having in Lombardy an exponential increase that was the case in the past weeks. And moreover, we have limited the contagion to the central and southern part of Italy, which is now, at least at the moment, under control. There are several outbreaks also in the south, but they are at the moment kept under control. So we are already thinking about an exit strategy back to business as usual, but to what I call a new abnormality, because you can imagine that the new, the back to the situation where we were before can be achieved only when we have a specific care, a specific drugs for this disease and the vaccine. And this is not certainly the case in the next months, at least for the vaccine. Maybe that for the therapeutics, we will be lucky enough to find some procedures that help us, but certainly, again, this is not a matter of weeks. So we have to be prepared to the next phase, which is, of course, living with the virus, as we have done with several other germs in the past. In this case, with this respiratory virus, I think it would be helpful, and this is something that we are studying, to increase our testing activity. I mean, testing is very important. At the beginning, we tested only the clearly symptomatic patients at a very advanced stage of the disease. Now we are going to test early symptoms, and we are also going to test the people that have had the disease and have spent their time at home before releasing them into the society. We are testing all the healthcare personnel. So we are extending the testing strategy. And of course, this is a serious organizational and economic implications. But we are also developing a kind of approach which is very much similar to what South Korea did. So linking the testing to hyper technological tracking, which means that we are trying to link with mobiles, with apps, the status of the single individual to something which clearly say to us if the individual is immune in the sense that has developed antibodies, if he's susceptible and healthy, if he's positive, and if he's contagious, if he or she is contagious, and so giving and studying for him or her a kind of digital passport via mobile that may help the society to go back to a much more active living and production, and of course to the country which is struggling not only from the epidemic and health point of view, but also from the economic point of view. So I close it now, and of course I hand over to you. I'm very happy to have your question, to answer to your question if you need it.
Excellent. Thank you so much, Professor Ricciardi, for an amazing presentation and a brilliant insight into the Italian experience and response to the virus. With some nice comments coming in here and some questions too. So our first question is from Susan Wendt, who says, again, thank you, Professor, for a fascinating review. This pandemic already is and will continue to be, or to provide, a rich case study for public health. In your opinion, which interventions across the world will be determined to have been the right thing at the right time?
What I've seen is that the governments that have underestimated how quick is the spread of this disease have made important mistakes. That was the example, for instance, of Spain. Spain has been warned by us. We have had a special relationship with the scientists of France and Germany. Unfortunately, that was not the case with Spanish scientists. We ourselves advised in a meeting in Brussels the Spanish government to act, but they didn't actually. In fact, they authorized the mass gatherings in Madrid, in the rest of the countries. They didn't stop football matches. They authorized mass gatherings such as on March the 8th, mass gatherings of women in the center of Madrid with thousands of people. So, and you see the consequences. So I think the first is lockdown, social distancing. Is if you are not able to stop the disease immediately, as they did in Taiwan, in Vietnam, in Korea, in Singapore, but they were used to do that because they had the same shock in 2015 with MERS. So they had the same delay, the same mistakes. So they were used now to react promptly. And rather than having a lockdown, they immediately activated a strategy of test, track, and contain. And that was not the case for European countries that wait too much, maybe understandably. I'm not blaming anybody for this. But when the disease is spread, there is not the possibility to contain anymore. So the strategy is to mitigate. So the answer is, at the beginning, is test, track, and contain. When the disease is spread, is lockdown, and then test, track, and to contain to make people mobile again.
Excellent, thank you. You touched on Korea there as one of the countries as an example. So our next question is from Ricardo, who says, the WHO is a beacon for us all, but it's important to check if other experiences or models are working, such as the Korean one. Could these models be tried too, and can you tell us something about them?
Yes, the Korean government is I think, is the example of a good practice because they were extremely shocked by the failure that they had in 2015 with the MERS. So the director of the CDC immediately put into action what she learned in 2015. So essentially what they did is, and they had also an unlucky event, but better than us, because it was not a nosocomial. They had a mass contagion by a religious sect that made in this specific group thousands of cases. So essentially they started testing all of the people that were in contact with these first cases. And so they activated a campaign of swabs and diagnostics but essentially in the very early symptoms. So they followed WHO guidelines, but in a very extensive way. So they tested immediately tens of thousands of people, and then they tracked them. So whenever they found a positive, they immediately tracked with the mobile and with applications the people that were that have been in contact with this positive. So they tracked them, and then they, of course, quarantined them at home mostly.
So we'll move on to our next question then. So Peter Lackman has asked, how can countries in low and lower middle incomes, of lower or lower middle income, do it differently given a lack of resources?
Yeah, the problem, as you may imagine, is that low and middle income countries do not have any or very low level of preparedness, in particular for diagnostics. That was the case why Tedros used a very, very tough encouragement words. You may remember that one was to make, in particular, an African government to understand how the threat was serious, that the terrorist, the virus was worse than terrorism. That was, of course, an image that shocked many people, particularly in the Western world, but that was not to the Western world. That was mostly to the African countries that, of course, experience, and Asian countries that experience every day the threat of terrorism, to understand that they had to act, because at that moment, which was mid-February, no single country, in particular no single African country, had acted in limiting or in even taking into account any measure to contain the disease. And then in March, he made another plea, which is test, again encouraging not only African but also South American and Central Asia governments to start a more active campaign of testing. Of course, many countries simply do not have the capacity to do that. That's why WHO has supported them with sending them help, testing kits, healthcare. I was saying that in particularly the WHO sent support diagnostic kits and healthcare personnel, particularly to Africa. And of course, that doesn't solve the problem, because still the capacity in low and middle income countries remains low. But certainly this is something that we have to address because this is a pandemic. And of course, it's the only possibility that we have to work together in every single countries in the world. So we have to take care of this.
Excellent, thank you. Our next question is from Sharon, who's in Australia, who says, in Australia, we're expecting 2 waves of the virus as the weather cools here. What are your thoughts on this second wave? Can you comment on this?
Yes, there are speculation about the fact, and it's very interesting to listen what's happening in Australia, because this is a new virus and nobody understands and nobody can predict whether it has a seasonality as the seasonal flu, that it prefers the cold part of the year. So essentially, we are afraid that when it's going to be cold in some parts of the world, that could be a second spread. That's why we have to develop new public health tactics, I would say, that make us able to live with this virus. And of course, it means that social distancing is still going to be important. Protective measures are important. And hopefully, actually, after this meeting, I had the weekly call with the chief scientific advisor to the government, the exchange of information for genome sequencing, for clinical trials, for vaccine development is going to be important. I can confirm that I've never seen such a coordinated effort worldwide. So I'm afraid that there will be a second spread in some countries according to the different seasonality, and hopefully we will be getting some times in order to tackle them.
Excellent, thank you. Our next question from Peter is, if we plan for the future, what can we do, or what do we need to do? Can governments plan for a future pandemic?
Yes, I think so. I mean, most of us, if not all of us, were aware that the pandemic, a pandemic, was going to come sooner or later. We didn't know exactly the time. But if you read again the paper written by Bill Gates on the New England Journal of Medicine is impressive for not only his visionary skills, but also for the advice. You know that Bill Gates is now much more engaged in philanthropy and in particular in fighting infectious disease and developing public measures, particularly in poorer countries. And I must say, I read the papers in Geneva at the WHO meeting in 2018, and I was shocked by the accuracy, by how precise the paper was, not only in envisaging the risk, but also in advising, in proposing solutions. Never hurt. And this is the kind of optimistic bias that affected certainly the governments all over the world, but also the public opinions, I must say, because the public is generally reluctant in times of peace to take some tough measures, or at least to be active in preparing. And as Bill Gates said, this is the kind of preparedness that very much resembles the military actions. So he proposes, you remember, not war games, but germ games. And I think that is going to be the time to do that in the future. And I'm sure that, and I hope, even with our support, I mean, we are scientists, healthcare people. I mean, we shouldn't be now reluctant to be more active in pushing governments to be now more prepared in the future for this than they were in the past.
Excellent, thank you. Our next question from Robert Palla. Can you comment on the apparent higher mortality rate in Italy than in other countries? And could it be due to a lower measured infection rate?
Yeah, of course, there is not a simple and one answer to this. Certainly, I would say the first is the age structure of our population. Italy is, with Japan, the oldest countries in the world. 23% of our population is older than 65. And in some area is even more than that, such as in the north of Italy. So if you take into account that the median of the age of people in hospitals in China was 46 and in Italy was 63, you can understand that a certain number of patients of elderly age was in hospitals, and certainly with, as I said, with previous comorbidities. And these were the age groups where the death rates were higher. The second reason is social. When you have, as my colleague in Lombardy said, in 2 weeks, the same number of cases that you have in 1 year, you can understand that the pressure on the healthcare is so strong that it's a miracle that they managed the way that they managed. But certainly that didn't allow them to provide the same level of quality of care to everybody that they could have done in cases of much more preparedness. I don't think that anybody can be prepared to have an increase of workload of hundreds of times in 2 weeks. But again, I guess that the mortality is higher in cases where the pressure on hospital is stronger. The third is that, as I said, the outbreaks was mostly in Lombardy, and Lombardy is the best place in Italy for hospitals, but certainly not at the same level for public health, which means that they didn't have adequate, at least I would say adequate, the quality of public health and territorial health care that they had in hospitals. So this means that many people stayed at home and elderly people died at home because there wasn't enough general practitioners and territorial care to take care of them. We estimate additional burden of people that die at home would be around the 3,000 cases. And last but not least, the death coding in Italy, I may say, is very generous in comparison with other countries. If you look at Germany or France, they tend to attribute the death by coronavirus only to the cases that where they assess that the coronavirus caused a direct causation of death. While in Italy, every single person that because of the coronavirus or with coronavirus making severe comorbidities much stronger is coded at regional level as it is. So I think these 4 factors have made the highest lethality rates in Italy higher than in other countries.
Hey, excellent, thank you. Our next question is from Tammy, who's asked, any insights on containment versus mitigation strategies in countries like South Africa, which has a high burden of HIV and TB?
I guess that the best approach is, of course, the sooner the better to contain. And containment means what I said. I mean, testing, tracking, and then containing. If you don't do that, the sooner you can do that later, but unfortunately with a more severe level of spreading of the disease. And certainly in countries such as South Africa, which have a quite strong percentage of population affected by other diseases such as HIV, I think it would be important to contain rather than to mitigate.
Excellent, thank you. Our next question is from Nina, who said, thank you for the amazing presentation. Was there any use of the rapid test in Italy? I'd be grateful for your opinion on the use of rapid tests for patient screening. Thank you.
Now there is an incredible push from commercial entities by government, particularly local government, and by people to have this rapid testing. We have a task force who is assessing these. Unfortunately, there is a lot of confusion. Some of them are not reliable. Some of them are not enough sensitive and specific. So you have to be very careful. It seems that there are some that are particularly good and advanced. I mean, maybe our Australian colleagues can say something on that. It seems that Australia is doing well from this point of view. Something coming from China, something from US. But yes, there is the problem, and certainly there will be an incredible commercial push for that. There are already commercial entities that are selling this test for anybody who wants to buy them on the internet. And I guess that is add confusions. But we are trying to do that on a more organized way with a task force inside the National Scientific Committee. And we are checking what kind of advice to give nationally.
Excellent, thank you. Our next question from Ricardo. How effectively can we rely on herd immunity if there's a second wave of this contagion? Are there additional measures that could be taken then?
I'm very skeptic on this approach because this is a new virus. We don't know what kind of immunological response provides. Of course, we can imagine that in the same way that other coronavirus do, there is an immunity. I don't think it's a live immunity. I think it's a relatively short immunity, as other flu or coronavirus. So it's a month immunity. And this, of course, adds doubts to the fact that herd immunity could be a solution to this virus. There are situations in which you can reach herd immunity only either with a vaccine or either with the majority of the population having the disease. And this is not advisable. This is what I said to the Secretary of State of the United Kingdom. And apparently he was somehow shocked because apparently their scientific advisors went in the first start of the epidemic for these solutions, which I don't think is wise, because in practice means that millions of people are going to have a disease and thousands of them are dying. And that is not only elderly people, it's also young people and people that are immunocompromised, people that have premorbidities. So I don't think that anybody can ethically and politically support this.
Excellent, thank you. Our next question is from Stephen in Nigeria, who said, thank you for the presentation. How were you able to ensure the continuous supply of basic needs, including food, water, and medications during the lockdown? What advice will you have for LMICs like Nigeria, where a significant proportion of the population live on less than $2 per day and are dependent on daily income?
Yeah, I think the answer is twofold. For say countries that have less wealth, I think what Vietnam did is very advisable. So Vietnam, when they made a complete lockdown, the government granted $2.5 a day to I don't remember if households of each person. So essentially, the lockdown was granted that people were, quiet because of the fact that they could buy foods, could buy essential goods that were not included in the lockdown, but they were granted to be available. The case in Italy is similar from a certain point of view. The complete lockdown was complete for any kind of activities, but not for the food chain and for essential activities. So there was an exemption, and up to now, everything is going well. And concerning the support, the money, there are urgent measures for the government to give money to people because actually, particularly in the south, which is relatively underdeveloped and certainly much poorer than the north, there were already people that, having lost their income, started to complain and to make even violent actions to get food. So you must have a government that takes responsibility and not only grants public health measures and scientific measures timely, but also grants with money to people, direct to people, and with a careful management of the essential production of food and other goods, other essential goods, that this is kept.
Excellent, thank you. Our next question is from Ingo Hartel, who's asked, how does Italy connect the experiences of the frontline workers, so receiving feedback from problems in executing strategies, with the central planning?
This was a problem because in Italy, we have a national health service that is regional based. So essentially, the central government has only three mandates, which is planning, setting the essential level of care, so choosing the basket of care that has to be granted to every Italian citizen, and funding and controlling. The management of healthcare services is regional level, and there is no way that the central government can take a management on an organizational decision unless there is a special law, which is a decree law, which is actually the case that the Prime Minister, that the Italian government took. So there was a call of a state of emergency, and the way in which the government ruled was essentially by decrees, which somehow obliged the regions to take the same actions everywhere. Certainly, that was not the case the first month. In the first month, there were incredible variation in the decision making at all levels, organizational, clinical. Now it's not again, but at the beginning the situation was somehow difficult to manage from the central government. Now it's much better, but still that doesn't solve the fragility of countries such as Italy, Spain, and even Germany, that have a system which is very much delegated, or even a federal system that is totally delegated to lenders, such as in Germany. They did pretty much the same. So Germany made a special law, and Spanish declared the state of emergency. But certainly when you have an epidemic, having this kind of governance is not adequate enough.
Excellent, thank you. Our next question is from John Brennan in Ireland. So how do you see this pandemic evolving over the coming months and years? What role could testing for acquired immunity play in this?
I see that, again, we will have to live with this virus maybe for the rest of our lives, and we will find a solution only when we will have a vaccine. So that means that social distancing and testing and tracking will be our main activities. It's what's happening in China. You know that Wuhan has reopened, but that was also the case in other neighboring countries. Now they have an active, productive, and mobile life, but certainly with careful behavior, both from the social point of view and the productive point of view. So factories have been open again with a very careful attention to distancing or to wearing PPE when it's possible. I think that wearing masks will become the new norm, because even you know that surgical masks do not protect from getting the disease. They protect from emitting droplets And this is going to be the case because whenever we have still the virus circulating, any single droplet can be dangerous. So I see, unfortunately, some months of a new norm in which everybody is going to wear masks, and there's going to be an increasing social distancing enforcement, and of course testing and tracking to contain the virus.
Excellent, thank you. Can we use the lessons from Ebola, Zika, MERS, etc., and other epidemics in the past? It seems that we do not transfer learning internationally.
Yeah, actually, I think that now the lessons is learned. I mean, if I take the European Union, now there has already been joint procurement for everything, for PPE, for ventilators, for drugs. So the idea, at least in the European Union, to work together from this point of view is now taken seriously and actually practically into account. I hope that this is going to be for the world. It's going to be difficult at global level because WHO, which is the main actor in this situation, unfortunately has only a normative power. And member states, I've been a member of the Executive Council for 2 years now. And when it comes to increase the power of WHO to be more active and to be more effective in this situation, there is still a strong reluctance and strong resistance by many member states. And another thing that it's shameful is that many member states don't pay their annual fee to WHO. I think that there are at least 60 countries, including some major countries, that have not yet paid 2019 annual fee to WHO. So essentially, the global collaboration is going to be difficult if the main actor is underfunded, even in the ordinary fees that should be given to WHO, and has only a normative power, so can exert only a kind of moral suasion. But at least in European Union, I think that something is seriously changed, and now the European Union is really much more active, putting money and also organizing better for preparedness.
Excellent, thank you. Our next question from Stephen is, while I understand that it is beneficial to test as many people as possible for COVID-19, resource constraints might not allow for this, especially in LMICs. What minimum level of testing or category of people would you recommend to be tested to ensure as much coverage as possible to limit the spread of the infection?
I would say the early symptoms. So essentially, everybody that has an early symptom, just some fever, a cough, a cold, a strong cold, high infection. I think whenever there is a very early symptom, so not wait for the symptoms to be, much stronger, to have them all together. So the sooner. And this doesn't mean asymptomatic, means pre-symptomatic or pauci-symptomatic. I know it's very difficult and sometimes philosophical, but whenever you have early symptoms, you should start testing. Then another testing would be for people that spend their time at home, which have a much less severe form of the disease. Whenever they are clinically okay, they have to be tested at least twice, which was not the case, at least in Italy in the past months. So they simply went back to the society, and some of them were still contagious. And another testing would be for healthcare personnel, particularly the one which is in contact with vulnerable patients. So I think that these three groups, so early symptoms, people that are clinically okay after the disease at home, and healthcare personnel and essential personnel would be the one that should be targeted. I don't think it's feasible to target everybody, even if the test becomes more available from the technical and the economical point of view.
Excellent, thank you. And I think we have time for one last question from Giulio, who has asked, could you please outline the strategy in Italy for the coming weeks?
Italy is now working hard on preparing the next phase. We believe that April, now we have, the government, I think today is prolonging the lockdown for 2 more weeks. My feeling is that this is going to happen for the whole month of April. Of course, this is a political decision, but I guess that in the month of April, the country will be still locked down, or at least a slowdown, which means that only essential activities will be granted, and the rest of the population is encouraged to stay at home. Why I believe that if we are able to launch this phase 2 of a much more extended but still targeted testing, as I just said, and also linking this to a mobile app which essentially declares the immunological status of every single individual, I think we could free most of the population to come back to activities, social and productive activities. This has serious privacy implications because this is what they did in China and in Korea, but China is not essentially a full democratic country, while Korea it is, but certainly there is a stronger sense maybe of the importance of limiting freedom when it comes to epidemic. In Italy, we are analyzing that. I must say that the whole cabinet and the whole authorities, even the one that protects the privacy of citizens, is open to discuss it. So we are confident that the two approach, testing and tracking, will make possible for Italy to go slowly back to a new abnormality.
Excellent, thank you. And thank you so much, Professor Ricciardi, for taking the time to speak with us today. I understand how busy and hectic your schedule is, so we really very much appreciate it, and we'll start to wrap up there. And yes, just to say again, thank you for the brilliant insight and lessons from Italy, which are applicable all over the world. We have a huge international audience here at ISQua, and I think from the comments and the questions, it seems to be it was very relevant and helpful to everyone who joined us today. And yeah, just a reminder as well, the recording of this will be available, so whoever couldn't make it today, please feel free to share the recording when it's available with anyone who you feel may benefit from it and who could help. Again, sincerest thanks to you, Professor Ricciardi, for joining us today.
Thank you to you. You're welcome. Thank you very much. Bye-bye, everybody.
Bye-bye. Just a quick note to everyone who's still on the line, we do have 2 upcoming COVID webinars, one later on today, a live Q&A with Professor Jason Leach and Dr. Dominique Allwood. That's 3 p.m. UTC +1 time. And also on Thursday, 2nd of April, tomorrow, we have a webinar with Seattle Children's Hospital's Interim Chief Medical Officer and leader of the hospital's COVID Emergency Command Center, Dr. Ruth McDonald, and the Medical Director of Infection Prevention, Dr. Danielle Zer. Again, just this webinar, I think, really highlights the strength of the ISQua community and everyone rallying together. So if you want to get more involved in the ISQua community, please have a look at our membership options and join ISQua to support us what we're doing. So yeah, that's it from us. Thank you very much, everyone, for joining us here today. We hope you enjoyed the webinar, and we'll hopefully see you later on today at the next one.